now. Okay. Well, thank you so much, Daniel. Let me introduce myself. My name is Imran Khawaja, and I am a sleep physician and a psychiatrist at Hennepin County Medical Center. I'm also associate professor of neurology at the University of Minnesota School of Medicine. Now, I have organized this lecture series a year ago as well, and we're going to do it again. I've invited several other lecturers and faculty members from different universities, and you'll be hearing from them in the next few months. So let me give you an overview of what you'll be learning before we go into our topic today. So as a part of Apna Merit lecture series, for the sleep medicine lecture series, you'll hear about introduction to the field of sleep medicine today. And then we'll have several lectures including fatigue mitigation, which is really important because a lot of our physicians are sleep deprived. Then you learn about introduction of sleep disorders, sleep apnea, parasomnias, intrinsic hypersomnias, restless legs syndrome, insomnia, and circadian rhythm disorders as well. Now, one thing I want to emphasize is that this is not necessarily just related to psychiatry, because sleep medicine field, as you learn in this lecture today, and I would encourage all the different specialties, including internal medicine, neurology, pulmonary critical care, as well as family medicine, and even ENT, because they also participate in the field of sleep medicine by performing different surgeries. So let's move on for today. The goals and objectives of the sleep lecture series is obviously to provide an introduction about to various sleep disorders, and at the conclusion of this lecture series, I'm hoping that the participants will be able to recognize major categories of sleep disorders. They're going to be able to initialize treatment and also refer patients for treatment when necessary, patients who are suffering from different sleep disorders. Also, participants would be able to coach their patients about the importance of sleep and the effects of sleep disorders on our health. So this is the faculty for the whole course. Again, you'll get the dates and details from Daniel in the future, but you can see I'm over here, as well as Dr. Malero, who's an assistant professor of medicine at the University of Minnesota. She's given a talk before. Dr. Michael Howell is a very senior, actually he's become an associate recently, and he is the training director for the fellowship program, area of parasomnias, which include Rem Sleep behavior disorder and sleepwalking, and he will be giving at least 1 or 2 lectures. Dr. Louis Cazaglis is on the faculty of internal medicine and sleep medicine at University of Minnesota. He will also at least give a couple of lectures. Fritz John Knoll is a fellow, he's an addiction psychiatrist and finishing up with sleep medicine. He'll be talking about couple of sleep disorders. Then a couple of other colleagues originally from Pakistan. Dr. Bilal Salat is a neurologist in Baltimore. Wad is also a psychiatrist and a sleep, used to run the training program at University of Mississippi, but now he's moved on into private sector. So let's move on to today's topic. So today's topic is introduction to a multitude. So let me just read you this quote about sleep. Sleep is an intermediate state between wakefulness and death, wakefulness being regarded as the active state of the animal and intellectual functions, and death as that of their total suppression. So this was a book, a sentence from The Philosophy of Sleep, book by Robert McNish, a member of Faculty of Physicians many years ago. So we didn't know much about sleep until recently. In contrast, this is a book from 1989. Alan Hobson, who's a researcher and has done a lot of research, especially in the area of dreams, he wrote about sleep, saying more has been learned about sleep in the past 60 years than in the preceding 6,000 years. If you think about this statement, you can apply this statement to any other field, but sleep is no exception because we have learned a lot about sleep in the last 60 years. Okay, also want to put in a plug-in for our APA, American Psychiatric Association's annual meeting, which is going to be in Toronto this year in 2005 in May. And I'm along with my colleague Tom Hurwitz here. I co-direct a course on sleep medicine. So interested in coming to the APA course as well. We've been doing it for the last several years. Okay. So let's move on. Let's talk about sleep medicine as a specialty. So what you'll be learning today is you learn about the history of sleep medicine, how this field evolved, and you learn about what it has become as a subspecialty of medicine, psychiatry, and neurology. You'll also learn about basic sleep-wake recording and regulation, how we record sleep in human beings. You'll learn about basic principles of polysomnogram, and you'll see a lot of pictures. You'll also learn about what happens when we fall asleep in terms of neurotransmitters, what neurotransmitters get active, what are not active, what is a flip-flop switch. You would learn about that as well. Okay, so here is a map of our presentation. In history, you learn about the pioneers of our field and what major advances have taken place in the last several years. In sleep medicine as a specialty, you learn about what are the different disciplines. Because part of my efforts are, along with my colleagues in Pakistan, as well as some of them here, is to develop the field of sleep medicine in Pakistan. And I was recently visiting Pakistan, and I met with a number of people and talked to them about the field. And our goal is to increase awareness about sleep medicine, as well as develop some sleep centers which could in future train sleep medicine physicians. So coming back to the different disciplines, you learn about board certification, how it is evolved in the United States, and then you learn about basic sleep wave recording. Okay. So let's learn about some brief history about sleep medicine. Now we have been learning about REM sleep, and you all know what REM sleep is. REM stands for rapid eye movement sleep. What happened back in the name of Dr. Kleitman was working with one of his interns, and he was trying to record EEG of people who were sleeping, and he did a lot of experiments on the number of volunteers as well as his child. Now he had his child plugged to all the wires and all the EEGs, and one day he realized that his child, while he was sleeping, and the child's eyes were moving quite rapidly, because sometimes, as you can see, that when we sleep, especially when we are children, close and you can see the eyeballs moving, and movements were rather quick. And he thought that maybe the child is going through seizures, but he looked at the EEG and he pulled some EEG wires, put around the eyes, and see that the eyes were really moving, and you can see those movements in the EEG. So that's what he noticed, and he found that this is the time when a person is sleeping and having rapid eye movement. He woke his child and learned that the child was having dreams. So he learned sleep, we are generally dreaming. So that was a major advancement in the field back in 1953. Before that, whether we dream in REM sleep or not. Bill Dement, who was working at that time at Columbia University and later moved to Stanford University, he did a lot of work with REM sleep and increasing awareness of sleep, importance of sleep, and various sleep disorders. He's generally considered as the father of modern sleep medicine. He's still alive and he's semi-retired, but he still comes to the meetings. This is another picture of Dr. Dement when he established a sleep center in 1977. Now, Stanford is considered as one of the largest and most advanced sleep. Moving on to the place where I work, simultaneously things were going on. I mean, there were people who were doing a lot of research. Back in the 80s, there were other discoveries going on. Sleep apnea became quite important disorder. Now, this gentleman, Carlos Schenk, who works at the sleep center where I work, he is Minnesota Regional Sleep Disorder. Both of them were partners, and they were interested in sleepwalking, patients who sleepwalk, patients who get violent during their sleep. So back in 1986, Carlos Schenk was doing a clinic in psychiatry, and one of his patients came and told him that he is having a problem where he sleeps, but then in the middle of the night when he's dreaming, he is actually dreaming very violent dreams. Not just that, he's also out these dreams. Now you'll learn in the future that we know that muscles are paralyzed. So Carlos Schenk thought that this might be having some PTSD, this gentleman. He talked to Mark Mahal, and then they did some sleep studies on this patient, and lo and behold, they found that this gentleman, when he was in his REM sleep, his body was not paralyzed in REM sleep, and he didn't have that mechanism in which REM sleep is paralyzed. So they were able to discover that there is a disorder known as REM behavior, in which people, when they are in their REM sleep, do not lose their muscle tone. Because in general, a big discovery in the field in 1986. Brad Bovee, who's a colleague and a mentor as well, he works at Mayo Clinic. Later, he collaborated with Mark Mahal and Carlos Schenk, and they found out that there is a strong relationship between REM behavior disorder, meaning the people who act out their dreams, and Parkinson's disease, which was also considered as a major advancement in the field of sleep medicine. Later, Christian Guilleminault also wrote some seminal papers on sleep apnea. Christian Guilleminault is a French neurologist who moved to America back in the 70s, and he worked very closely with Bill Dement at the Stanford University. Then what happened in 1980s, this gentleman who's still alive and is working from Australia, he created a CPAP machine, and he created a CPAP machine from just a regular vacuum cleaner, because as you know, all vacuum cleaners suck air. He just was able to turn that around, meaning instead of sucking air, the vacuum cleaners start blowing out air, and he used a mask, a very primitive mask, on one of his patients who was struggling with sleep apnea and was having difficulty breathing, and he was able to successfully treat obstructive sleep apnea. So that was another major advancement. Since then, many newer versions have come, including some of the bi-level machines as well as some of the adaptive servo-ventilation machines. So this was a major advancement in those years. Moving on to what happened to sleep medicine as a subspecialty. The sleep medicine is a multidisciplinary specialty, meaning specialists from different disciplines participate in that. Now these are the specialists who go into the field of sleep medicine, and especially in the United States. You look at internal medicine, all the subspecialties. Now, I know a lot of cardiologists who have gone into this field, but mostly pulmonary critical care physicians, internal medicine, psychiatrists, neurologists, family medicine physicians, but also anesthesiologists and ENT. Actually, I was in FJ, Fatma Janam Medical College, and I met with Professor Sami Mumtaz and his team, because he is an ENT specialist, and he is also interested in establishing sleep medicine services at FJ. Then back over the years, for the last several years until 2007, sleep medicine was a separate specialty, but it was not included in American Board of Medical Specialty. So it was sort of considered separate. But in 2000 year, American Board of Sleep Medicine was gone, and sleep medicine became a formal specialty under American Board of Medical Specialties. Now, until 2011, people who were practicing sleep medicine were able to take the exam and be boarded. But after 2011, anybody who wants to practice sleep medicine has to do at least a one-year fellowship, and then the person becomes board eligible for sleep medicine. Now, psychologists who used to be able to get boarded back when there was a previous sleep medicine board now have to have a separate behavioral sleep medicine. Moving on to basic sleep rate recording and regulation. Okay, I'm going to move on. So in terms of what we do when we record sleep, there are different ways we could do it. I'm going to show you what are the different ways. For example, we can do it with an actigraph, which is a very basic device, and it only tells us about simple sleep, but I'm going to show you it in a minute. Okay. Actigraph is a device which basically records activity, and it tells us what time a person is sleeping versus what time a person is awake. It doesn't give us any information about sleep EEG, and we use it to document sleep. For example, patients who are going to complete a sleep diary, and we want to document what their sleep is like or how many hours of sleep they've been getting over the last few weeks, we use actigraph in those patients. This is how an actigraph looks like. It's a very basic tool. As you can see, these areas suggest activity because there's a lot of activity going on. The arms are moving. And when we are awake, we move a lot. And when we go to sleep, even though we think that we move, but we do not move a lot. So these periods are suggestive of sleep. So as you can see, this person has been sleeping regularly. There's some sleep. So active is a good idea about or not. Let's move on to polysomnogram, which is a typical sleep study. This is how it looks like. As you can see, a person who is going through a sleep study is hooked up with multiple wires. You can see here, there are EEG wires which record brain activity, electrical activity. Then there are sensors around the nose and the mouth which record the airflow, which you will also see in a minute. All these wires, but then here a person has an oximeter which records oxygen saturation. And these are belts which obviously when a person breathes, the chest and abdomen, they grow bigger in size. So the movement of these belts are translated in sleep study, which tells us whether they are breathing, not breathing, whether it's an obstructive apnea or a central apnea. I'm going to go through these slides a bit. This is how the equipment looks like. These are a few years old slide. Now the person who gets, the sleep technologist puts these wires on a person's head. They have to scratch the skin slightly and glue these wires on a person. We use International 1020 system of placement. You can see these processes, how it is done. And you can see these bands, chest and abdominal bands, and also motion sensors for detection of limb movements, because there's some sleep disorders, for example, restless legs and periodic limb movements of sleep, which we can detect during a sleep study. You can see nasal pressure sensors here, which are recording the airflow. And then obviously these are leads which are recording chin EMG, actually, muscle activity. This is the oxygen saturation curve. These are the technologists to see the sleep study. Okay, so how does sleep look like on EEG? As you can see these EEGs, how do we differentiate sleep, different stages of sleep? And again, I won't expect you to learn all this, but as you can see in stage 1, so this is EEG, these are eye movements. In stage 1, EEG is it's not a very high amplitude, it's slightly fast and gets slowed down, whereas the eye movements are not that strong, they're kind of like slow eye movements. But when a person goes into stage 2, which is considered as a consolidated sleep, the EEG starts showing these K complexes. K complex means an upward as well as a downward event, like this is a K complex, as well as it starts having some spindles. And these EEG spindles have a different frequency, certain frequency. In stage 3, you can see some slow wave, as you can see from these. And stage 4 and stage 3 are now combined into one stage called stage 3. And in REM sleep, the EEG looks like of a person who's quite awake, because in REM sleep, most of the time people are dreaming. But as you can see, these rapid eye movements can be appreciated in REM sleep. This is what Kleitman found when he was doing a sleep study of his child, that the sleep EEG looks like somebody's awake, but these rapid eye movements, because these rapid eye movements, most people think that these are eye movements because when we are dreaming, we are looking at objects, so that these eye movements are basically tracking that. So here is what we have. We've got wakefulness and we've got sleep. And during sleep, we are either in a non-REM sleep or we are in a REM. What happens when we are in wakefulness? We are totally awake. We know what's going on outside. Our EEG frequency is sort of low wave, mixed, higher frequency. Obviously, when we are awake, we are blinking, so eyes are movement. This is how wakefulness looks like, because as you can see, there's muscle here, quite active muscle, because somebody's awake. These are blinking eye movements. In non-REM, when a person gets into non-REM, EEG becomes a bit more synchronous. EMG starts going down. In stage 1, which is usually 5 to 10% of the total sleep, there is slow eye rolling movements. The person starts getting a bit drowsy. There are sometimes vertex sharp waves. So this is how stage 1 looks like. This EEG is considered as alpha and is awake. But then here you can see there's some slowing here. So this is sleep, or N1 sleep. N2 stage, usually the eye movements cease. And EEG resembles of stage 1, but as I mentioned before, you can see some K complexes in spindle activity. Here you can see, for example, these are spindles, fast activity, which is in the range of 12 to 16 Hertz, whereas these are the K complex, sort of upward and downward complexes called K complexes. In stage 3, for example, there is further slowing of EEG. As you can see, there is slowing, sometimes called as delta waves. You can see a lot of slowing waves. And in REM sleep, which is sort of a paradoxical sleep, there is low voltage activity, phasic rapid eye movement, and the skeletal muscles are totally atonic, meaning the muscles are paralyzed. If somebody is in REM sleep and you do a reflex on that person, you're not going to get any reflex. That's another thing, that they're going to wake up from that, but then you're not going to be able to elicit any reflexes. Most of the time, people are having vivid dreams in their REM sleep. This is how REM sleep looks like. As you can see, the EEG is mixed frequency, not very high amplitude, but you can see sharp, rapid eye movements. Now, this is a slide showing what happens to us when we are born and as we grow old. As you can see, when a baby is born, baby is getting what, 50% REM sleep here and 50% non-REM sleep. As we grow old, the REM sleep starts going down, and then after that it stays the same, but generally still from the age from 50 to 90, there's not much change except that the quality of sleep gets a bit worse. But in general, from adulthood, the sleep remains pretty much the same. The amount is close to 20%. Now, another test which we do, which I didn't mention before, other than the polysomnogram, is that we do multiple sleep latency test. This is a test which we do after a sleep study, and this is a test which we do to diagnose patients with narcolepsy. This is simply an opportunity for a patient to take naps 2 hours apart, and we see how quickly do the patient. So if a patient is falling asleep within less than 8 minutes on average on these 5 naps, and then REM sleep occurs in 2 of these naps, and actually the mean sleep latency is less than 5, that is clear-cut narcolepsy. I'm just going to skip this slide. So you've learned about actigraph, that we record activity and it tells us about sleep. Then you've learned about some basic principles and how polysomnogram or a basic sleep study is done. Now this is the third portion of the recording of sleep. This is what we call as portable monitoring. This has become quite popular and the field is going in that direction. Now these are different devices which can record sleep to some extent, not necessarily through EEG, but through some other autonomic systems, but also can detect whether a person is going through sleep apnea or not, meaning we can send patients home with these equipment and they can come back and we can know whether this person is having obstructive sleep apnea. But these equipments are mostly for patients who have straightforward sleep apnea, not for patients who might have seizures, not for patients who might have parasomnias like sleepwalking or REM behavior disorder. Okay, now let's move to this next section, which is about what happens to us when we are sleeping, what happens to us when we are awake. As you can see that our brain consists of various neuronal systems. As you can see here, locus coeruleus, raphe nucleus, these are histaminics, VLPO. These are different bodies, neurons, which have different neurotransmitters. Now, another neurotransmitter which is very important is called orexin or hypocretin. This is a neurotransmitter which is produced in hypothalamus, lateral hypothalamus, and which is very important for regulation of sleep and wakefulness. Now, this is the neurotransmitter which is gone or is reduced in patients who have narcolepsy. Now, what is thought is that this neurotransmitter has projection to all the different areas of the brain, and it is responsible for maintaining one state versus the other, meaning that if a person is awake, certain neurotransmitters are turned on, whereas the sleep neurotransmitters are turned off, and this orexin keeps the balance. If you take this out of the equation, the person, meaning that the person can go from one state of sleep, say for example wakefulness, into REM sleep rather. For example, look at this. This is a slide. I want you to think about being awake and being sleepy as a flip-flop switch. This was a major article written by one of the scientists named Dr. Sapir, who talked about this flip-flop switch. Different neurotransmitters, for example, histamine. These are neurotransmitters which, when turned on, makes us more alert, whereas some of the neurotransmitters, for example GABA, is responsible for more sedation. So when these neurotransmitters are turned on, they automatically suppress the GABAergic neurotransmission. So it becomes a flip-flop switch. When these neurotransmitters are active, a person is awake. As you can see, the switch is turned in that direction, and it turns off the sleep neurotransmitters, which is GABA in this case. Whereas when a person is sleeping, the neurotransmitters like histamine, serotonin, norepinephrine, acetylcholine are turned off, whereas GABA is turned on. So when this is turned on, these neurotransmitters is sleeping. Now we talked about hypocretin. Now hypocretin, what hypocretin does, it keeps the balance, meaning it keeps one state versus the other. And if you take out hypocretin, just like what patients with narcolepsy have, meaning they don't have any hypocretin, it becomes very unsleepy very easily, and their sleep is fragmented. They're sleeping to waking up. And okay. Now another model which I want you to understand is the two-process model of sleep-wake timing. So what happens here is that there are two processes. One process is called process S, which stands from homeostatic process, meaning the more a person is awake, the longer or the more sleep drive that person is going to have. So if you're awake for 24 hours, for example, you're going to get more sleepy because you're going to have more sleep drive. However, there's another process which is called process C, or circadian element, meaning that in a 24-hour period, you're going to have certain times where more sleepy versus other. You have a bit of a dip in alertness around 2 to 3 p.m., which is after lunch, and then at night there's a dip. So everybody, irrespective whether they're sleep deprived or not, they get a bit sleepy at around 2 to 3 p.m. and at night because of this process called process C. Okay. Now, components of sleep and wakefulness becomes dysregulated, dissociated from parent state, and recombined in maladaptive relationships. For example, patients who have insomnia, patients with hypersomnia could have different processes going on. For example, they might have narcolepsy, or if they have obstructive sleep apnea, their sleep states are being disrupted. Now I'm going to stop here because this is just an introduction, and you'll hear a lot more from me as well as my other colleagues. And I'll stop here to take any questions.
Dr. Imran, do you want me to give them mic?
Yes, please. I'm done for this.
Okay.